am going to present unusual cases of facial pain, mainly Eagle syndrome and Snuder's neuralgia. Actually, there are many causes of facial pain, but my concentration is Eagle syndrome and Snuder's neuralgia because it is underdiagnosed cases. And we are getting a lot of cases, but initially we were not thinking of this identity, so we were not able to diagnose it properly. But somehow in my mind came that we should diagnose it. So started diagnosing, we are getting a lot of cases. So these are important differential diagnosis for facial and cervicopharyngeal pain. Includes Eagle syndrome, then temporomandibular joint dysfunction, laryngopharyngeal anesthesia, hyperpharyngitis, Snuder's syndrome, glossopharyngeal neuralgia, then esophageal diverticula, trigeminal neuralgia, migraine type of headaches, sphenocarotid neuralgia, cervical arthritis, temporal arthritis, unerupted or impacted molar teeth, faulty dental prosthesis, otitis, different type of otitis, then salivary gland disorders, and possibly some tumors may also create some sort of facial pain. Actually, I have started one small study. Till now, I have diagnosed 13 patients with having Eagle syndrome. And among these 13, 8 are females and 5 are males. In a study regarding Eagle syndrome says that the female to male ratio is 3:1. Here we are getting, we got 5 females and 8 females and 5 males. And the patient's age were between 33 to 72 years. They were assessed clinically. That I saw a picture. Actually, we have to palpate the tonsillar fossa with finger, so we can feel the impression of styloid process in the just lateral to the tonsil. Through the tonsil, we have to palpate the styloid process, and on palpation, patient will feel the same pain which he was complaining of. Most of the patients coming to me with ear pain. They are saying I got otalgia. Then we'll examine, nothing is there. I will find nothing, then I will go for this palpation and I will get this. And on palpation, he will have this pain increase. Then we can confirm by injecting some local anesthetic like xylocaine or sensoricaine over the tonsillar fossa. So after injecting this injection, he will not have any pain on second palpation. This is the way we diagnose it. Then to confirm our diagnosis, we order orthopantogram of styloid process. तो कैसे किया सर वो बता रहे हैं. After that we confirm it as Eagle syndrome. Then there are medical and surgical management. Medical management we will discuss later. Surgical management is tonsillectomy with removal of styloid process. And till now I have done 8 surgeries for Eagle syndrome in this hospital. This is how we palpate the tonsillar fossa. Get feeling of styloid process and recreate the pain in the ear or lower down the throat. These are some of the X-rays which we have taken. Here, this patient, small projection is there. This is the styloid process. This side is not very clear. So this X-ray is not good quality. And this is, I think, my first X-ray I ordered for orthopantogram. Other X-rays are very good. This you can see clearly. This styloid process is a lab. It should be up to this level. This is extra level. Both sides it's a lab. And here small part. This is stylohyoid ligament calcified. Here a small gap is there. This may be pseudoarthrosis or pseudoarthrosis, something like that. This is another X-ray, a male patient. Here, this is the styloid process. Here you can see it very beautifully. This is tonsillectomy. After the tonsillectomy, we expose the styloid process and a ring curate, we open as far as possible the part of styloid process, then break it and remove it. This is styloid process. This is another case. This is a removed specimen compared with the needle, the size of the styloid process. This is another one. So, Eagle syndrome is a specific orofacial pain secondary to calcification of the styloid ligament or elongated styloid process has been known as Eagle syndrome. And this is discovered by Bart W. Eagle in 1937. Initially, he thought that this is only because of some sort of orofacial trauma or due to tonsillectomy. But later on, as the evolution goes on, this non-traumatic, non-surgical cases were also included in Eagle syndrome. It presents as nagging dull pain, long-term pain in the throat, sometimes radiating to the ipsilateral ear and the sensation of foreign body in the throat. And occasionally we can find odinophagia, dysphonia, increased salivation, and the styloid process is cylinder outgrowth at the base of the temporal bone, immediately posterior to the mastoid apex. It lies caudally, radially, and anteriorly towards the maxillovertebral pharyngeal recess. It contains a lot of structure, includes carotid artery, internal jugular vein, facial nerve, glossopharyngeal nerve, vagus nerve, and hypoglossal nerve. With the stylohyoid ligament and the small wall of the hyoid bone, the styloid process forms the stylohyoid apparatus, which arises embryonically from the research cartilage of the second ventricle. Eagle defines the length of normal styloid process as 2.5 to 3 centimeters. So, this is styloid process, mastoid cave, and sonographic canal. From here, one ligament comes to stylohyoid, to hyoid bone, stylohyoid ligament, and gradual calcification from this point to this point may lead to irritation of nerves or vessels, whichever comes in the way, leading to the symptoms. These are important structures which comes on the pathway. This is styloid process. Internal carotid, external carotid, then a lot of nerves. Any one of them may get compressed or irritated. An elongated styloid process occurs in about 4% of general population, while only a small percentage between 4 to 10.3% of these patients are symptomatic so far. So the true incidence is about 0.16%, with a female to male predominance of 3:1. Bilateral involvement is quite common, but does not always involve bilateral symptoms. Styloid process may be enlarged both sides, but symptoms may be unilateral. So this is Langley's classification of enlarged styloid process. This is the normal styloid process, and if it is reaching up to the angle of mandible, it is type 1. Sometimes there may be pseudo articulation, and sometimes there may be many segments reaching up to the hyoid bone. This is class type 3. Regarding pathophysiology, it is still debated. Somebody says something, somebody says something. So these are theories given behind the genesis of the symptoms. So the first person, Eagle, said that due to surgical trauma like tonsillectomy or local chronic irritation could cause osteitis, periosteitis, or tendonitis of the stylohyoid complex with consequent reactive ossifying hyperplasia, which can irritate the surrounding nerves and vessels, leading to symptoms. Then this gentleman, Lentini, in 1975, says that persistence of the mesenchymal elements, that is Richard cartilage residues, could undergo osseous metaplasia and consequent symptoms. Epiphanio, in 1962, the ossification of the styloid process was related to endocrine disorders in women at the menopause. That's why the reportedness of this disease is more in the women. Then this person, Gropsy C. et al., said that ectopic calcification, especially patients with abnormal calcium metabolism, phosphorus and vitamin D metabolism as in industrial renal disease. This disease can occur.